Hello, everyone, and welcome to a panel discussion on wastewater surveillance in Illinois, lessons learned from COVID-19 and future directions. My name is Anna Marotra, and I am the director of the Wastewater Surveillance Program at the Water Environment Federation, or WEF. WEF is pleased to be hosting this webinar in collaboration with the Metropolitan Water Reclamation District of Greater Chicago, or MWRD. We are grateful to our fantastic moderator and our impressive panel who are going to work together to bring you up to speed on wastewater surveillance in Illinois. Before I introduce our moderator, I wanted to mention two items. First, this webinar will be recorded, and we will share the link to the recording once it is available in an email to all webinar attendees. And the second is that our panelists really do want to answer your questions. So please go ahead and type your question in the Q&A box at any time during the webinar. And with that, it is my distinct pleasure to introduce our moderator for today's webinar. Kimberly Neely Dubuclet was elected to the MWRD Board of Commissioners in November 2018. As a native resident of the South Side and a lifelong Chicagoan, she is proud to serve the residents of Cook County. Commissioner Dubuclet is chairman of the Federal Legislation and Labor and Industrial Relations Committees and vice chairman of the Budget and Employment Committee, the Pension, Human Resources and Civil Service Committee, and the Stormwater Committee. Prior to joining the MWRD board, Commissioner Dubuclet served as the Legislative and Community Affairs Director for the Chicago Park District, where she worked with community organizations and elected officials around the city and state to improve parks and park programming in Chicago. Commissioner Dubuclet previously served as a representative in the Illinois General Assembly for the 26th District. As a commissioner, she is working to increase environmental awareness of environmental justice issues throughout Cook County, and to increase open green space for communities while providing additional green infrastructure opportunities for water conservation. Commissioner Dubuclet earned an MBA from the University of Chicago Booth School of Business and is active in numerous community organizations, including Alpha Kappa Alpha, the Links Inc., and the Girlfriends Inc. And she also serves on the Museum of Contemporary Art Women's Board and the Quad Cities Development Corporation Board. So thank you, Commissioner Dubuclet, for all your service and leadership. And I'll go ahead and turn it over to you.
Thank you so much, Anna. And just a brief correction. I should correct that in my bio. I'm a former member of the Women's Board of MCA. So I don't want them to see that and say I made a mistake. So we have today 5 panelists, and I think it's my responsibility to read the bios of all 5 panelists. So please bear with me while I go through all these bios, because it's very important for all of us to know who's joining us today. The first one is Dr. Richard Tran, and please correct me if I misspoke that, Mr. Tran. Perfect. Dr. Tran is an infectious disease epidemiologist and the new molecular surveillance director at the Chicago Department of Public Health. Richard helps lead Chicago's efforts monitoring COVID-19 variants and wastewater testing. He initially joined CDPH as a CDC Epidemic Intelligence Service Officer at the beginning of the COVID-19 pandemic, and he has supported investigations of COVID-19 outbreaks in a variety of settings, including hospitals, nursing homes, skilled nursing facilities, gyms, and facilities. That's Dr. Tran. The next panelist and bio I'm going to read is for Dr. Charles Williams, or should I let Dr. Tran present first and then read the other bios? I'm not sure which is would be more effective. Maybe I'll read through all the bios and then we'll go back into the presentations.
Yeah.
Okay, Dr. Charles Williams, one of our second presenters, is the Chief of Testing at the Illinois Department of Public Health, otherwise known as IDPH. He is responsible for the overall state strategy for the testing of diseases, disorders, and harmful substances affecting public health. He also serves as the executive leader for the Illinois Wastewater Surveillance System, leveraging his extensive experience in quality management and population health to shape the program that covers all 11 COVID-19 regions here in Illinois. Charles earned a Master of Public Health from Columbia University. Our next panelist is James Wint. James is the program manager at the Illinois Department of Public Health for the Illinois Wastewater Surveillance System. James first joined IDPH during the height of the COVID-19 pandemic at the IDPH Chicago Laboratory, and in May of 2021, under IDPH Bureau Chief of Testing Charles Williams' leadership, he coordinated with the Discovery Partners Institute to develop and launch IWSS. James is a proud born and raised Illinoisan and a New York University alum. Kaylin Patterson. Kaylin is an associate environmental microbiologist at MWRD, where she's worked for over 8 years. She supervises MWRD's fecal coliform analysis for water and biosolids and ensures the microbiology laboratory continues to maintain compliance with IDPH's drinking water certification standards. Kaylin started Steward Surveillance Coordination in March of 2020 with Stanford University and participated in Water Research Foundation's International Summit on Environmental Service Surveillance of COVID-19 Indicators and Sewer Sheds in April of 2020. She then continued leading MWRD's surveillance participation by establishing partnerships with UIC, DPI, CDC, NWSS, and others. She currently participates in Water Environment Federation's NWSS's Utility Community of Practice. Dr. Rachel Poretsky hails from the great urban microbial hotspot of Brooklyn, New York. She obtained a BS in biology from Brandeis University and a PhD in marine sciences from the University of Georgia. She was a postdoc at Caltech in geology and planetary sciences at Georgia Tech in environmental engineering. She has done pioneering work looking at genes and gene expression of microbial communities in the open ocean and in freshwater lakes and rivers and wastewater. She is currently an associate professor in biological sciences at the University of Illinois in Chicago, where she has been since January of 2013. So that was a mouthful, but I hope everybody now understands where we all come from. So next, I think I have Dr. Richard Tran to present.
Can you just confirm that you can see my slides?
We sure can.
Great. Okay, so hi everyone. As it's just detailed, my name is Richard Tran. I'm the new molecular surveillance director for the Chicago Department of Public Health, and I oversee all genomic and wastewater surveillance for COVID-19 across the city. So I'll get started. So wastewater sampling gives us the opportunity to detect and monitor numerous infectious diseases in a pooled sample of water that can then tell us information about thousands of people at once. One of the great things about wastewater surveillance is that it is additive, meaning that it adds a lot of additional context and information to how we traditionally do public health work, not just locally, but across the country. Traditionally, public health departments get positive test results from laboratories, and those test results are normally reportable to the Department of Public Health. However, these traditional sources of information are limited because they depend on people seeking healthcare and also having the means to pursue testing. I think COVID-19 has provided us with a great example as to why traditional public health surveillance is not enough. The way people see COVID-19 testing has changed throughout the pandemic, with more and more people testing at home using rapid tests. And the majority of these test results never actually make their way to a health department. So the data we currently have on COVID-19 cases are only a small snapshot of what is actually happening in our communities. Wastewater surveillance allows us to monitor infections like SARS-CoV-2 among thousands of individuals, independent of persons' health-seeking behaviors, access to healthcare, or testing. Also, testing wastewater is fast and results could be available within 48 hours. So it's a really efficient form of public health surveillance that's available to us. So the Chicago Department of Public Health has developed a wastewater surveillance program in collaboration with IDPH and the Discovery Partners Institute that allows us to monitor SARS-CoV-2 across the city of Chicago. We use 3 different approaches, including testing wastewater from treatment plants, local sewers, and high-risk facilities. On the left of the screen is a figure that depicts the 3 treatment plants that currently serve the city of Chicago. The dotted line outlines the city limits, and as you can see, each of the 3 treatment plants cover an area of the city in addition to the portion of the surrounding Cook County. Each of these plants cover more than 1 million people and is the most zoomed out description of what is happening in these areas. At this level, if we detect SARS-CoV-2 in samples from these treatment plants, it's very hard to determine if the virus is originating from inside or outside of the city of Chicago. Because of this, we also wanted a more granular description of what was happening within the Chicago city limits. So to do this, our second approach was to select different local sewer sites within the city limits among community areas known to have less access to COVID-19 testing and access to healthcare. The figure on the right indicates the sewers where we sample from and the residential area that is covered by that specific sewer. And you can see this in the blue shaded areas on the city map. So overall, everyone in the city of Chicago is currently covered by one of these 2 sampling strategies, with the treatment plant samples describing COVID-19 trends occurring across approximately 5 million people, and our 7 sewer sheds describing trends among a sample of 230,000 people within the city of Chicago. Lastly, we also conduct facility level sampling across 3 different sites, including O'Hare International Airport, Cook County Jail, and Misericordia Home, which is a behavioral health care facility in the city of Chicago. Data from our wastewater surveillance testing is reported to CDC on a routine basis to describe current SARS-CoV-2 virus levels across different regions of the country. On the left of the screen is a screenshot of the CDC website where you can click and zoom in or out into specific testing locations across the city, and it details whether virus concentration levels are increasing or decreasing. Additionally, CDPH also provides routine data updates on its own website with our most recent trends that we're observing within the city of Chicago. You can find our website by Googling Chicago Wastewater Surveillance, and our page is the first link that appears on the Google site. I've also included the URLs at the bottom of both screenshots for future reference when you get access to the recording. Data from wastewater is unable to tell us how many people are currently infected with SARS-CoV-2. However, it's informative when you start monitoring sewage virus levels over time. This figure depicts virus level trends over time at some of our testing locations. And monitoring trends over time can help us determine if virus levels across the city are stable, increasing, or decreasing over time. These data also help us characterize how we're doing across the entire city of Chicago. So on a weekly basis, the city of Chicago tries to summarize our COVID-19 risk across the city. And we use our wastewater surveillance to help try and characterize how we're doing as a city. And we rank our risk on 3 different levels: low, medium, or high, which is consistent with how CDC's community transmission levels for COVID-19 work. Additionally, when we detect SARS-CoV-2 in wastewater, the city of Chicago, along with its partners, also tries to characterize the variants that are circulating in our wastewater through sequencing. This type of analysis gives us the ability to detect new and emerging variants of concern that may lead to an increase of cases throughout the city. For example, both of the figures on this slide detail the types of Omicron lineages that are currently circulating at different testing sites. On the left, you can see that on the week of September 7th, over 80% of the virus that was detected at O'Hare was Omicron BA.5 sublineage. Similarly, on the right of the screen is similar data detailing Omicron lineages at testing sites such as the Cook County. So our program is relatively new at the City of Chicago because we did not have this type of surveillance capacity before the COVID-19 pandemic. And we are working every day to improve our strategy for COVID-19 and provide frequent updates on what is happening across the city. Moving forward, we're also exploring testing other viruses and are in the very early stages of testing wastewater for flu and monkeypox. We're also exploring the possibility of testing polio. And lastly, I just want to end by thanking and acknowledging that none of this work would be possible without the collaboration of several partners, including academic institutions, government agencies, and private entities. Thank you.
Thank you, Richard. I believe our next presenters are Charles Williams, along with his colleague, James Wendt. Is that correct? Are you co-presenting?
That's correct.
Awesome.
Thank you.
Take it away.
All right, let's see if we can share slides as well. Really appreciate Richard's presentation, and it dovetails quite nicely with the work that we do at the state level. So we'll zoom out a little bit, and as we cover our territory here, let me just see if this works. Let's see. I do screen two. Sorry. Am I sharing my screen right now? You probably saw my email for a second. Is that true? All right, well, thanks a lot, everyone. So yes, I'll be sharing, co-presenting with James Wendt as well. And I really appreciated Richard's presentation also because it just gives a bit of the history of the program. As we got started, we were trying to figure out how to get this off the ground. We loved it because at the end of the day, this acts as a leading indicator. Our wastewater surveillance acts as a leading indicator that we can use. It's a fast turnaround that we don't see, as Richard said, with our clinical sampling. It takes time for an individual to get sick enough to show up at a clinic, get tested, or at a testing site, get tested, get those results, and then for us to aggregate all of those results from across the state to understand the level of spread. That takes time. That may take weeks. And then additionally, if you tack on, after you understand the spread and then you take those samples and actually sequence them, that can take an additional number of weeks. But what we have here, again, a leading indicator, fast turnaround time. And so with our program, I'm going to go into this and we're going to talk a little bit. And let's see, we'll go over really quickly our footprint and our attributes, and then we're just going to talk about the future similar to how Richard did. But basically, so we finally launched our program in May of 2021. And what we've experienced is a real boom in terms of going from 10 sites in 10 counties to today, where we're now at 75 sites across 47 counties. So this really, it excites me when I give that statistic because I know the work that went in to getting this off the ground and our partnership with DPI, as well as the Chicago Department of Public Health, really just speaks to the great work of these teams. We so far not only sampled 5,000 samples and sequenced just as many, so that we understand the variants, but we also, as Richard said, we report to the National Surveillance Program, and we also have a few pilot programs in process, which we'll share with you as well. This is a little outline of our program and our footprint. So what you see here is the collection, moving from collection to transport to the lab, as well as our total footprint. And then finally, our genomic sequencing, which I explained. And you can see our footprint here. And I'm actually going to pass it to James to cover a few of our strengths of our program.
Hello, everybody. Good afternoon. Oh, good. My Wi-Fi is going to hold up for a little bit. All right. As Charles said, my name is James Wendt, and I am the program manager for the Illinois Wastewater Surveillance System on the Illinois Department of Public Health side. I help coordinate the day-to-day, and I'm very fortunate to work with my colleagues at Discovery Partners Institute, like Dr. Paretsky, our partners at Chicago Department of Public Health, like Dr. Tran, as well as utility operators like Kaylin Patterson, who we will have the opportunity to hear from in just a moment, as well as all over the state, including that footprint that Charles just shared with us. One of the translations from that geographic coverage to population is we are currently, through the Illinois Wastewater Surveillance System, collecting data on 8.1 million residents of Illinois. We continue to try and increase both the geographic coverage, but also our population coverage, especially as we move toward the pandemic being an endemic disease with us, making sure that we're getting information even when those other resources may decline. We're very proud that our program is competitive with other large state programs. Richard showed that screenshot from the National Wastewater Surveillance System. You can see that Illinois is well represented, and that is, as he mentioned, and as Charles has acknowledged as well, tremendous collaboration between many different folks. Charles also spoke to the track and trending of SARS-CoV-2 lineages over time, and this really helps not just understand illness, but also perhaps things like treatment, right? Where do we need to, and Charles will speak to this as well, where do we need to implement resources to really start to contain, right? One of the real benefits, especially like I said, as we continue to move in different stages of the pandemic, is the cost effectiveness of this strategy. Choosing one of the MWRD plants as an example here, which serves about 1.2 million folks. Our per cost sample from everything from the collection on up to sequencing right now is about $525. And taking that over our population here, rather simple formula, we're looking at 0.00042 cents per person for that surveillance, which is incredibly cost effective and something that we hope will continue. That's one of the real robust areas of this program. Finally, two of the things that have been mentioned by both Charles and Richard are those pooled sequencing results for regional profile of variants. We're able to add to the existing clinical sequencing that we're doing to really color in that picture and build out that image. Finally, it is a snapshot of community spread that's independent of that clinical testing. So, and I appreciate the way that Dr. Tran had indicated this or articulated this, everybody poops. So they're going to be captured in that surveillance. Thanks, Charles.
And so thank you, James. James has been he's been a real powerhouse in getting this off the ground and working with all of our partners. So I so appreciate James's work on this. So ultimately what this does for us is we triangulate the data that we get from the analyses and tracking and trending of our wastewater data. And we really look at that alongside other key metrics, and that helps us in our public health decision making. And so when we get the information from the DPI lab, we might look at it alongside of vaccinations within a community, for instance. We'll monitor, and we continuously monitor our bed availability in our hospitals, but we might look at whether we're seeing a spike in hospitalizations as well. And then we also look at the testing resources available in those communities where we're seeing an increase in spread. And then we may, ultimately, the messaging may say, you know what, we recommend, or the local health department may decide to recommend increased testing in that community. They'll look at their testing resources in that community and assure that there's availability of testing resources. And also we look at circulating variants, because we want to know, maybe there's an association with a particularly infectious variant that, you know, maybe it spreads quickly, maybe the effects are more severe than others. And so we're monitoring all of these key metrics alongside of the information we're getting from our wastewater. but ultimately it helps us make public health decisions. This is an example. I really like this example because a while back, we saw the increase in spread in Beardstown, and working with their local health department, they did that very thing. They said, you know what, we need to get the message out, encourage individuals, because at that time they had lower vaccination rates. We want to make sure that they're getting tested so that we can interrupt the spread that we're seeing. This is just a quick look, but we do these monthly reports with our partners at CDPH, and you all should be receiving those. We're really proud of that. We actually surveyed our stakeholders, both treatment plants and LHDs, and we actually came up with a single metric approach as well, similar to how Richard was talking about, where we look at the high, medium, and low spread in terms of its regional presence, regional severity, and then we make our public, this is again, we are putting this alongside other variables and making our public health decisions. And again, this is a look at how once that wastewater is sequenced, we're looking at that and we're monitoring and comparing for the prevalence of certain variants. I'm going to fast forward, but I want to also emphasize that when we look at alongside of the clinical remnant sequencing, we often see that they complement each other, and we're monitoring that so that we can see if a certain variant shows up in wastewater at one point in time, and then we monitor that, and we want to see if it shows up later on in our clinical remnant sequencing. So moving forward, this is just a look at the future of where we're going with our program. And right now, we've got a few new places that we're beta testing our collection efforts in Veterans Affairs and our veterans homes to keep our veterans safe, and also schools. We're looking at K through 12 and doing some testing there potentially, and also new targets. We do intend to begin testing for flu. We'll be announcing that pretty soon, but also we're monitoring and making some determinations about testing for monkeypox as well as polio in our wastewater. And with that, I'll pass it back to Kimberly, and so that we can continue. Thank you.
That was very informative. Thank you very much. I believe our next presenter is my colleague at MWRD, Kaylin Patterson. Kaylin,
Yes,
awesome. Take it away.
thank you, Kim. And thank you, Charles and James and Richard, for your good presentation. It's always a pleasure to work with you guys and to see what you're doing with the samples that we collect. Next slide, please. So one of the things we really like, if you've noticed, is maps. Maps are very popular in sewage surveillance because obviously we're looking at location. So MWRD's service area has 7 water reclamation plants. And within those 7 water reclamation plants, we have 8 influent sources that we sample for our sewage surveillance programs. The population range at these 7 plants starts as low as 13,000 and goes to populations greater than 1.2 million people. So we do have a broad range of population. Our treatment volume for these plants is somewhat on a small to medium side, with 2.3 million gallons per day on average, and goes up to 1.2 billion gallons per day on average. So kind of a smaller, medium-sized treatment plants up to these very large treatment plants. And majority of our service area is combined sewers. So if you've noticed on Richard's maps and graphs, there is little comments for heavy rainfall on this day and heavy rainfall. So it's important for us to report precipitation. One of the lessons that we've kind of learned through this is when we started working in sewage surveillance, there's interest in which sample sites we utilize because of these various population size variances and the treatment size variances. And so it's kind of interesting to see what different academic teams, as well as which teams on the federal and state and local side want to utilize. And that part of that's just part of the development and proof of concept, depending upon what we have access to and availability for these programs that we're participating in. And so that puts all of our treatment plants on a little bit of a different sampling schedule. And so everyone, some of them are 5 days a week, some are 3 days a week. It really just kind of depends upon what is going on and what is happening. Next slide. So this is just kind of a graph about what our sample totals have been and where we have been since 2020 when we started. And it's broken down by our academic participation, our federal participation, and our state and local participation. So when we started sewage surveillance in 2020, in March of 2020, we worked with Allie Bain and Krista Wigington out at Stanford University and University of Michigan to kind of develop the program. You know, can we find this? Is it a good method? Can we develop methods? Getting the proof of concept together. And the third quarter in October 2020, we started looking and working more locally with UIC and Northwestern and Argonne National Laboratories to develop models closer to home here in the state of Illinois. When we shifted over to 2021, we kind of really built and worked on building that statewide participation and participating with UIC from an academic standpoint. In 2021, we also participated in the CDC news program. So they did sampling twice during 2021 for their federal program that covered the nation. And so we participated in that program as well. As soon as 2021 ended and 2022 started, we officially formally did kind of a transition to the state IWSS program. We completed our enrollment forms. We got on board with DPI and the teams at the public health departments. And so that's why there's kind of a big shift to the state and local at that time. We moved away from the academic to the state and federal partnerships. So far this year, from January to August, we've continued to participate in the federal news program. And we've also maintained some of our relationships with some of our academic partners. So that way they can continue looking at some of those newer targets and different sewage surveillance options and just kind of seeing what's out there and developing all of that. So in the future, I think what we'll see with this 2022 is hopefully see some more state and local participation, but also keep that federal component as well as that academic component for a different development for that. So that just is kind of a nice overview of what we've done for the past 3 years and how we transitioned from an academic supporting development and research side to actually working with the public health departments for the implementation of their programs and getting it in their hands so that way they can effectively utilize it. We don't analyze the samples on site. We pass them off to Rachel Paretsky's lab to do the analysis. So I will turn it over to her so she can talk a little bit about that.
Great, thanks. This is such a pleasure to go after everybody who really set the stage nicely. I just have a couple of slides that I wanted to share. First, to show you that we have this really big, diverse team, and these are just a sampling of some of the key leadership key members of our leadership team. And I think it's really helpful to see how we have this overarching goal that Richard and Charles and James, everybody has spoken about the public health benefits of this wastewater surveillance work. And we, Kaylin also set the stage for kind of the timeline of MWRD's participation. We actually also started in October 2020, and we started on a pretty small scale in Chicago as a sort of proof of concept, and then expanded statewide. And I wanted to give a sense of what that looks like and where we came from, especially in the theme of today's webinar about lessons learned and the future of our work. Great. So just a couple of stats about where we are right now. So prior to October 2021, when things moved to my lab, we processed about 1,500 samples in Chicago. We've since October 2021, we've processed about 1,300 samples from Chicago and about 7,000 samples across the state of Illinois. And we sequence almost all of the samples from the state of Illinois and many of the samples from Chicago. And we get between 100 and 150 samples a week right now, and almost all of those get sequenced. So the scale of what we're doing is just tremendous. And looking back to the beginning when we were establishing this program and establishing the methods, a lot of folks said it couldn't be done sequencing variants from wastewater, and thanks to Sarah Owens at Argonne National Lab and our whole team, we've been amazingly successful and have generated some of the data that Richard and Charles and James have shared today. So we started out early in 2020 putting this together, and we actually got our first samples in October 2020. And Abhilasha Shrestha, who's an assistant professor in the School of Public Health at UIC, really set the stage for this work in her lab. And we were processing the samples. These are MWRD samples in that top left corner that we got in 2020, and we were filtering them. And we had this great method that worked for the number of samples that we were getting in Chicago. But as we started talking about expanding the program, we realized that we were pretty tapped out with the method that we were using. It was time consuming, labor intensive, and just not scalable. And so as we talked about expanding this program to the whole state, we had to bring in automation and personnel to really grow the program. And we did that with robotics, with digital PCR, and with a team of people, some of whom are included on this slide. Adam Horton on the bottom left is a lab manager in my lab, Chiyu and Jarju. The next two folks are technicians in the lab, and then we have students, and we have a new staff member. So it really takes a lot of people to get this done efficiently and to process the number of samples that we're working on. So what's the future lessons learned? Well, a lot of lessons learned, but really the future, we continue to work on kind of modeling and constraining the uncertainty in our data, which is really important when values are really low, because either mostly because cases might be really low, but also to model that with epidemiological data. So cases, tests, and other types of epi data, which have changed over the course of the pandemic, due to testing changes, how many people get tested, where they get tested, how those tests get reported, but also vaccination, different variants, everything has sort of changed the landscape of the pandemic and changed how we interpret the data. And so this is an ongoing and future work to really constrain those models, understand the uncertainty, and develop things like that single metric that both Charles and Richard spoke to. So future, everybody before me has mentioned future targets, and Amy Kirby, the director of the National Wastewater Surveillance Program at CDC, shared these back at a WEF public health meeting several months ago, and was throwing around ideas for future targets, some of which are pathogens, and of course that's now expanded to things like monkeypox and polio that others have mentioned, things that are current and possibly future public health concerns, but also things like antimicrobial resistance genes. And so we have a new project that we recently started to look at antimicrobial resistance in wastewater. And so I think there's a lot of future targets, and I'm just kind of wrapping up there, that there's applications beyond COVID-19 that we're thinking about, and we have some really exciting work in development. A lot of this response to development of our methods for new targets has been in response to something. So once clinical cases of monkeypox are identified, a lot of people scramble to develop monkeypox assays for wastewater. So it's reactive, but the value of wastewater that Richard kind of led off with this, the value of wastewater is that we have that information already in the wastewater. We should be able to use these samples more proactively or prospective proactive analysis and not just reactive. I like to say that we shouldn't wait until there's a case of paralytic polio as an example in order to kick off a wastewater surveillance program for polio. That wastewater can really be used for not just public health decision-making processes, but for keeping people safe, alerting clinicians who maybe aren't testing or diagnosing everything. The wastewater, the information's already in the wastewater, and I think there's a lot of value there. So we have some exciting research going on to try to characterize wastewater and do broad level surveillance that's prospective and not reactive, or proactive and not reactive. I'll end there. Thank you.
Is there anything else for you, Kaylin? So we're all done? Perfect. Then I have some questions I'd like to ask each of the panelists. So I think I will start in the order in which we did the presentations, and that would be with Richard, if you're still there. You mentioned you mentioned earlier during your presentation that you selected various sewers within the city to gain more detailed information about what's happening specifically in Chicago. Can you describe how those sewer sites were selected?
Sure. And I actually have a slide on this, so I'm going to share my screen very quickly just to give an example. But I will say that as a public health department, one of the things that Chicago tries to do is when we are addressing or responding to a public health emergency interventions is really looking at public health issues through a lens of health equity, racial equity, and making sure that we are specifically investing our resources to the communities that need it most. With that said, one of the things that we did when we were examining the sewer sites that we potentially could take samples and test them for is we wanted to make sure that we were going to not only get a representative sample of the different community areas within the city of Chicago, but we also wanted to make sure that we intentionally chose sewer sites that also described the communities that we know have less resources, less access to healthcare, and are at highest risk for COVID-19 severe outcomes such as hospitalizations and deaths. What our teams of epidemiologists do is we've actually used two different metrics. It's called the TEPI and the CCVI. And what both of them do is they describe each of Chicago's 77 community areas based on neighborhood resources, but also vulnerability for severe COVID-19 outcomes. Using these two metrics, what we did is we mapped out the city of Chicago's community areas to see which community areas are the most vulnerable, and we selected sites using that approach. One of the things that we're actively doing at the moment is trying to select additional sewer sites or new sewer sites that can give us a bigger representation of the city of Chicago in order for us to be able to describe more of its residents. So that's kind of, that's a very long-winded kind of response to the question, but I think it's important context of the intentional nature of where we are specifically testing wastewater.
No, that was very helpful. Thank you. And then one quick follow-up. This answer may be obvious, but how does the city use wastewater data to form public health recommendations?
Yeah, I think Charles actually mentioned this briefly in his presentation, but we really see wastewater as being a leading indicator, because we know that it takes several days for someone to develop COVID-19 symptoms, to think, oh, I probably have COVID, or is it the flu, and then go to their doctor, get tested, have that sample go to a laboratory, and then for those results to make it to the public health department. That takes approximately a week, or if not more. One of the great things about wastewater surveillance is that the sampling is immediate. It's shed through the feces, it gets flushed in the toilet, it's readily available, and we're able to sample kind of what's going on in real time. And one of the great things that could potentially come from wastewater surveillance is that it could predict an increase in cases that we would not know about in time if we just solely relied on positive test results. So one of the great things about wastewater surveillance is that it can give us clues about where we are going in terms of community transmission from a city perspective, and give us time to prepare and allocate resources where they're needed.
Great, thank you.
Mhm.
My next set of questions will be for both Charles and James. What actions are taken when a sample shows that there's evidence of COVID in wastewater?
Hello again, everyone. I'll start with that answer, and then if Charles would like to add as well. What we're looking at, and we've spoken about this, Charles has spoke to it, and as did Richard, is this idea that we're looking at sustained trends over time. And it's not, a single action is never going to be taken off a single reading, because of the variability of environmental sampling, specifically with wastewater as well. That's why, as Kaylin said, it's so important to measure that rainfall, because even little variables like that can affect what we're looking at. And then, like Charles and Richard mentioned as well, is to take that information and put it in context with the other testing data, hospitalization data, and monitoring all of this together to really make sure that we're understanding what's driving those increases, and then always what's the public health action to mitigate spread.
Charles, did you want to add, or can I move on to my next question?
That's solid. Yep.
Okay, perfect. Do you all think that sampling will still be needed once COVID-19 is quote unquote no longer present in our community?
I'm going to say definitely, because polio is just one target in our portfolio of surveillance targets. So sampling is going to definitely be needed. We're going to need the partnership we have to continue, and even to be enhanced with our treatment plants, which we can't thank the treatment plants enough. I mean, for just on a volunteer basis, contributing to the health of the people of Illinois through this work. It's powerful, it's necessary, it's cutting edge, and I'm just thankful that they're participating the way that they have. So again, Kimberly, yes, we will continue to sample. We do need to continue to sample, and we need Rachel's lab to continue to do some amazing work and test more targets. So yes.
Can you speak to, I know you spoke to.
And I don't think it's going away, by the way.
Okay. Okay.
So that's the other piece.
The president said COVID's gone, so it must be.
Right. Yeah.
You spoke to it on a very high level during your presentation about future testing of polio and maybe monkeypox, other viruses. Is there anything else you can add to that?
I'll probably let Rachel kind of comment on that. There's always a balance between, you know, the public health. We're trying to balance what the lab can do, you know, lab capability with the, you know, actions that can be taken from a public health standpoint. And also we want to make sure that if we start to monitor something, we want to know that we can in fact detect it. We want to know that our you know, our assays have a high level of efficacy. And so that's what we owe to our constituents, right? I mean, when we put something out there, we want to make sure it's doing what it's supposed to do. And when we're giving associated public health actions, we want to make sure that they're reasonable, that, you know, they have an appropriate level of severity, and you know, that the alert to the public is appropriate as well. So all of those things we're, you know, kind of balancing and making the decision with whether to move forward with testing. I mean, I know that Rachel's lab has a high level of capability. She's worked with most of the people now, and I talk about Rachel. and she's worked with most of the people at CDC and everything anyway, and her lab has too. So they're often kind of forward when it comes to being able to roll some things out. So that's an advantage that Illinois has, is that, you know, we've got the technical capability. And so I think when we do make these decisions, they're highly reliable. And so, you know, that's definitely, as the third largest public health department, that's the level we should be, right? I mean, we should be leading, we should be putting out things with the high level of, you know, efficacy. Rachel, did you want to comment on that?
Well, I accidentally clicked on I will answer Nicole's question live. So it's appropriate because it falls into what you were talking about, Charles. So she suggested considering working with law enforcement to test for narcotics like opioids. And so we work, Richard mentioned this, with the Cook County Sheriff's Office, and we do surveillance at the Cook County Jail here in Chicago. We have a pilot program looking at opioids in partnership with MWRD and an academic team at the University of Florida that's developing methods for that. But to kind of piggyback on what Charles was saying, there's lots of targets. You know, we could, it's almost an endless list. I actually have a running list of potential targets that wastewater can be used for, but I was introduced to this term the other day called the worried well. People who are healthy, but start seeing that there's, you know, evidence of different pathogens or different public health concerns and start panicking. And I think what Charles started talking about speaks to that, that there's targets that we can go after, but we have to choose like what has a good public, what's actionable, what can we have a public health response to, what is meaningful. Depending on the target, there's various levels of compliance that we have to meet, standards that we have to meet depending on the particular target. So I think, you know, while there's endless possibilities of targets, there's also, we kind of have to constrain it to serving the public, having actionable data, and doing it in a way that's safe for the facilities, safe for the lab, and ultimately benefits public health.
I'm gonna toss this one out, and whoever thinks they have the answer. It may be for you, Charles, but whoever has the answer. Is there a correlation between the gene copies and the number of people that are actually sick?
Ooh, that's a great question. And one that's hard to answer. I'll say that that's a difficult one to answer, just because, you know, you're dealing with how each individual's body reacts to the virus. I mean, for some people, they shed a lot of virus. For others, it's less. So it's hard to say. You might have someone walking around who's, you know, asymptomatic, yet being, you know, spreading and shedding a lot of the virus. So, you know, it's kind of hard to say that when, you know, you get a reading in wastewater, how it correlates with each individual, you know, like each individual clinical case. I don't know that there's been, you know, real validated research on that that's come out yet, peer reviewed. That I don't think it's there yet to that. I mean, Richard or Rachel, or maybe there's something I don't know about, but that's hard to say.
Okay, well, thank you.
I was just going to follow up that it's tough. Exactly what Charles said is right. But that's partly why we have our modeling team at Northwestern that's doing a lot of modeling and data validation, because depending on different prevalence estimates, like looking at the epi data, we can sort of constrain that, maybe not to an exact number of people, but we can get population level information that may be really different. If we're, say, looking at one of Kaylin's facilities like Stickney, it's going to be really different than if we're looking at a plant downstate that serves 10,000 people. Like so it's kind of very site specific, and we are kind of validating that or trying to better understand it at a community level.
Thank you.
And then we do get baselines, like Rachel's saying, so that we can, those statisticians, they put that together to see if it's an actual statistical change that we're seeing. So, they figure it out, but that's, one to one.
Caitlin, this is for you, my agency. How do you think MWRD's role has changed during the pandemic?
I think we started, like I mentioned with the graphs, we started academic, and then we shifted more to this supporting the state and public. But, we obviously try and continue to support programs that support our mission and our goals. One of the first lines of our mission statement is to protect the public in our service area. And so that's always the forefront of our mind is, are we serving the public? We've established some criteria due to some of these limitations. I think Rachel mentioned, do we have enough sample volume? We have to internally look if we can handle that staffing wise within our lab. One of the areas that I would say has greatly improved from March 2020 to today is our communication with our state and local public health departments. I think we've really been able to establish these relationships and develop with them and work with them to establish these programs along with their contracted partners. And I think that's been important. In the spring of 2020, I think they were a little overwhelmed. The science advanced. We helped them kind of understand sewage a little bit better, provide a little bit of education. But we also had to make sure that, what we were giving them was beneficial. Do you need a full liter of sample? Do you need something smaller? And just kind of keeping those communications rolling with them, as well as the data flow and support. We collect a lot of data on our sewage, and we wanted to make sure that, was all of it useful? The statisticians want everything that they could possibly get, but does that muddy the results a little bit? And, what do you need and what don't you need? And so that's kind of, been interesting to us, but I really want to say that communication piece with our public health departments has drastically improved. And I really appreciate their support and their communication and working with us throughout the past 2 years on these programs.
And finally for you, Caitlin, in your opinion, what does the future of wastewater surveillance look like?
I really think, like Charles said, I don't think it's going away. And it's one of those things where like Richard shared, it's a good community pool. We're not looking directly at one house. We're not looking at one person. We're looking at a community as a whole. And I think that's really important to consider is that everybody flushes, everybody poops. We appreciate you contributing to that. It's a daily task that, hopefully we can just receive that. And that's where it's gonna continue. Obviously we're gonna have our limitations with the sample volume and our staffing, but I think we'll continue to support these programs as long as they're valuable to our public health departments. Without our samples and without our staff being able to do their job and collect them, even though they do it on a routine basis, obviously it's had a significant impact on our response to the pandemic. And, you got to give a shout out to those staff for, participating and doing their job, because without any of them or any of us, we don't have a robust program like this. And I feel like the state of Illinois program, as well as the one that City of Chicago has put together, is strong. And part of that comes from our participation.
Well, that's a great segue to my next question. And this is for either you or for Rachel. How is Illinois' program different from other programs around the country that do testing in their wastewater? What makes ours so superior? Which I believe it is.
Yeah, I'll start. Caitlin, if you want to add anything.
I think we need to wrap up in a minute too, so
I'll be super brief.
Okay.
I think we have such a diverse partnership that Caitlin kind of spoke to of facility partners, public health partners, clinicians, modelers, microbiologists, and we're all working together on one state. We're doing the same methods across the state. A lot of states have also there's some states that have big programs too, but they're sort of fragmented, or they're within academia only, or within a commercial partner only. And I feel like our whole network is shown by everybody who's here today, and the hundreds of people who are not here today, from plants downstate, all over the state, to lab members, to DPI partners, to all the people that work behind the faces that are on this call today. It's a great partnership.
Well, I appreciate the partnerships, and I appreciate all of you for participating today. And now with 1 minute left, I think I am tossing it back to Anna, right on time.
Yeah, that you guys are awesome. Thank you for this peek inside this. It is an incredible program. So I'm a fan. But thank you all for your time today. Thank you for everybody who attended. Just a reminder that we did record this webinar, so we will share that link with you all through an email. And I also put some links in the chat to some of the programs that were mentioned today. Please feel free to reach out to me at WEF with any questions. And thanks again for your time.
Anna, can you put those links in with the link to the playback of the recording?
I will. Yes. Great idea. I will certainly do that.
Thank you.
All right. Thank you.